What's up, Ninja Nerds? In this video, we're going to be talking about Crohn's disease. If you guys like this video, you learn from it, it makes sense, please support us by hitting that like button, commenting on the comment section, and please subscribe. Also, if you guys want to follow along with some awesome notes, some illustrations, go down the description box below. It'll take you to our website. Check that out. All right, Ninja Nerds, but before we get started on Crohn's disease, we actually teamed up with an awesome online resource called Chegg. Chegg is great. It's going to be able to help you with a lot of your undergraduate and your graduate needs. Let's take a look and see what Chegg has to offer for you. All right, Ninja Nerds, so the first thing I want to show you guys is go down in the description box below. There's going to be a link there, which is going to be having a promotion code for this Chegg website. So let's go ahead and check that out. So whenever you click on that link, it'll take you here. And again, the great thing that this offers for you guys is this coupon code for $5 off for your first month of Chegg Study Pack. And you guys can go ahead and check this out. All right, so here on this home website, we're gonna go ahead and check out this really cool thing here on the side called the Study Tools tab. It's gonna take you to this kind of other menu where you're gonna wanna click on this one called Check My Writing. And what I really think is cool about this is I'm not the greatest writer and I have mistakes in my grammar. So it's really cool. What you can do is you can take any of your papers, anything that you guys are writing for any course, and go ahead and paste all of that in here. Or if it's somewhere on your computer, on your Google Drive, you can obviously click and upload that onto this link here. Also, if you guys need some help, there's actually like people who will read your paper. They're experts in proofreading, and they'll provide you a summary, give you a bunch of different comments, and help you guys out in the best way possible. So I urge you guys to check this out. Go to this website. Make sure you, again, down in the description box below, we'll have a link. We'll give you guys that coupon code and check this stuff out. It has a lot to offer for you guys. All right, let's get to our video. All right, so let's talk a little bit about Crohn's disease. Crohn's disease is actually a category under the what's called inflammatory bowel disease. Inflammatory bowel disease actually consists of Crohn's disease, and it also consists of ulcerative colitis. So what I want you to know is Crohn's disease is an inflammation of the entire GI tract. This inflammation that we're going to talk about can occur anywhere along the length of the GI tract. Usually it's most common, particularly within the ileum and in the parts of the colon, but nonetheless it can occur anywhere along the GI tract. Now, this inflammation, or kind of an autoimmune type of behavior, what's it really due to? Well, believe it or not, we don't have a completely beautiful underlying idea, but there's some thoughts that we've seen with this. One of the big things is that there may be some type of immune involvement, and there may also be some type of genetics that are involved here. And what do I mean here? So our immune system is obviously targeting the GI tract, right? So we have different types of cells like macrophages. We have our T helper cells, which are also attacking the GI tract. And then we'll also kind of infiltrate some neutrophils via the chemotaxis process to come there and also cause some damage. What's kind of causing all of these cells to kind of really become very significantly going into the area and causing all this inflammation? There may be some kind of underlying immune dysregulation. Why is there this immune dysregulation? Not completely sure. But to give you kind of an idea here, our GI tract is very, very good at being able to, especially the epithelial cells that line the GI tract wall, they're very good at maintaining a nice barrier between what's in the lumen and what goes into the blood behind the actual epithelial tissue. And so, within inside of our lumen, we have bacteria, we have drugs, we have different types of things that are moving within inside of this lumen here. And normally, the epithelial cells are very, very good at maintaining an intact barrier and preventing things from just shifting right into the tissue, right? So what we've noticed is in Crohn's disease, this pathway may be somewhat altered, where the barrier may be lost. You know what happens? Epithelial cells, they're good at sometimes sampling some of the bacteria. And when they sample the bacteria, they say, ooh, this bacteria ain't no good, man. I don't like some of these bacteria. Let me destroy some of these so they don't overgrow in the lumen. And they release very specific types of proteins called defensins. One of the things that we see in these patients is that they may have a decrease in defensins. There may be some type of decrease in the alpha defensins. Alpha defensins are made by these very special cells within the epithelial tract called the Paneth cells. So Paneth cells are responsible for secreting defensins. In Crohn's disease, there may be a reduction in this. The other thing, goblet cells, they make mucin. Mucin is also important because it provides a nice barrier, a thick barrier between the bacteria, all this commensalistic bacteria, which is in the lumen, and the intestinal cells and underneath. And patients with Crohn's disease, we also see that there is a reduction in mucin by the goblet cells. You know what else? There's certain types of bacteria, especially like Mycobacterium paratuberculosis. It can get into our epithelial cells. When it gets into the epithelial cells, it kind of forms like these little vesicles inside. So let's say here's the bacteria. Here's the Mycobacterium paratuberculosis. It gets inside of these cells. Normally what happens is we have very special types of vesicles in here containing lysosomes. And what happens is these lysosomes will actually fuse with this vesicle containing the bacteria and destroy it. What is that called? Autophagy. In patients with Crohn's disease, what we see is a reduction in the autophagy process. So there's also a reduction in autophagy. Now, there's one very specific type of genetic thing that I want you guys to be aware of, right? There's a gene that's really important. I want you to think about it like the intestinal sampler. Think about it like it's one of those guys that goes around and tastes wine everywhere. It's running, anything that's kind of running through the GI lumen, it's just like tasting. It's like, all right, let me see what's going on in here. Oh, okay, I got you. I see what's in there. This guy, this gene, there's a gene in here that actually makes a very specific type of protein. It's right here. It's called the NOD2. NOD2 is this very specific sampler of bacteria. And what happens is in Crohn's disease, there's some type of mutation in the NOD2 gene where it's not really good at sampling the bacteria. And when it samples the bacteria, it's supposed to tell our immune system cells. For example, let's say that this bacteria, the NOD2, will take very specific types of receptors. It's an intracellular one. Let's say that there's a very specific antigen on that bacteria. It activates the NOD2. The NOD2 will then stimulate something called nuclear factor kappa beta, and this will release very specific types of cytokines. And what these cytokines will do is they'll tell our macrophages. You know we have these cells called macrophages? They'll be on high alert. It'll stimulate them. And when they're stimulated, they'll come here and play a role within immune surveillance. And they'll be like, hey, ain't nothing getting through here, boy. And so they play this very important role in immune surveillance. Now, another thing is, macrophages, when they're kind of activated to play their role within this immune surveillance, they also tell very specific types of cells called T helper cells. You know, these are very interesting cells. Probably not very talked about too often. They're called Th17 cells. Th17 cells release a very specific type of cytokine called interleukin 22. And interleukin 22 will tell some of these cells that are actually a part of the intestinal cells to make defensins, to make mucins, to increase the autophagy process. And the reason why is it's trying to prevent any kind of excessive growth of bacteria or really nasty bacteria within inside of the lumen. But guess what? In a patient with Crohn's disease, guess what's all jacked up? That NOD2 be all jacked up. And so because of that NOD2 mutation, you affect the normal release of nuclear factor kappa beta. This is still the debate, and this is why it's so confusing, is that some articles say that some of the literature says that it's a loss of function of the nuclear factor kappa beta. Some say it's a gain of function. We truly have no idea. But what we know is that whenever there's this NOD2 mutation, there's a loss of stimulation of macrophages. And so the immune surveillance process is decreased. Now some of the bacteria that's inside here can actually grow and pass through and translocate right into the area here. That's not good. So now I lose some of the surveillance and the ability to control bacteria from moving to this area. On top of that, if I inhibit the macrophages, then I inhibit the release of interleukin 22. I inhibit these cells from being able to do what? To release defensins and mucin. There's a reduction in that. Then I'm not able to break down particular bacteria with this protein called defensin. I'm not able to make enough mucin to maintain a good thick barrier. And guess what? The autophagy process is also decreased. You know what leads to this? This leads to tons. The bacteria just say, hey man, ain't nothing standing by the door now. I'm just gonna keep on growing and growing and growing. And so then you get all of these bacteria that just overgrow here. And this leads to an excessive growth of bacteria, especially really nasty bacteria. This is called dysbiosis. What is this called? Dysbiosis. And this can become somewhat problematic because you increase the number of bacteria and you increase the number of nasty bacteria that can actually cause problematic issues. Okay, That's one of the flavors of this. That's why it's so confusing. The other aspect of this, well, let's actually put down here. So what else did we say here? Not just these things, but we also said another thing that really reinforces a lot of this is that NOD2 mutation. Very, very important. Okay, it's one of the big genetics, the big genetic factors here that's really been kind of linked with this process. And the last thing that maybe is related here is that there may be very specific cytokines. We're not going to get into it right now. We'll talk about it in just a little bit. But there may be an increase, an over-exaggerated increase in very specific types of cytokines that are produced. And we'll talk about these. Interleukin-6, TNF-alpha, and interleukin-17 seem to be the ones that are very problematic. And we'll talk about them a little bit later. Okay, so these are the things that we've kind of seen associated with Crohn's disease on the immune genetic end. The environmental end is what we're still not really sure about. So what do we know about this? On the environmental end, so we have immune composition here that's involved. So there's three things. It's kind of like they usually use like a circle sometimes, like a three-part circle. So we have immune involvement, some type of dysregulation, some type of genetic predisposition. And then the third thing that I want you guys to remember here is environmental. Now, there's some factors here that I want you guys to think about. So what are some of the environmental factors? So what we have seen is maybe there's certain types of infections. Remember I told you one of them was the Mycobacterium paratuberculosis, Listeria, certain types of infectious species like that may be linked to it. Also antibiotics. So antibiotics actually have been linked to it. NSAIDs, believe it or not, have been linked to it. And you know, it's a really interesting one. It seems to be the only really reversible risk factor associated particularly with those patients with Crohn's disease is, you know what it is? It's very interesting. Smoking. Smoking seems to be a very, very interesting type of risk factor. So don't forget this one, okay? Because this is one of those that you can actually somewhat modify in patients with Crohn's disease. There's other things as well that are maybe associated with this, like diet, but any of these things are what's linked to Crohn's disease. It's a kind of a multifactorial type of component. There's some type of immune, genetic, and environmental involvement that is producing this disease. Now, let's come back for a second. We know that if there's a problem with all of these defensins, the mucin, the autophagy, the NOD2, what starts happening? Well, all of this, you lose the ability to break down the bacteria, you start losing the barrier, and you start losing the ability to maintain a nice intact barrier. What starts happening? As the barrier becomes lost, these bacteria start translocating across the epithelial tissue. What is this called? This is called bacterial translocation. Because of all these problematic issues with Crohn's disease, you have an increase in bacterial translocation. Okay, here's where things get a little bit heated and intense. Once these bacteria get in here, they activate some very special cells. Any kind of antigen presenting cell, really. So let's say here, you get an increase in the bacterial translocation. So here's some nice bacteria. They get into this area. Once they get into the area, the macrophages will become exposed to them. Once the macrophages are exposed to them, you know what the macrophages do with these bacteria? They phagocytose the bacteria. When they phagocytose it, they process it, they take a piece of the antigen on the bacteria and present it on itself. You know they present it on what? They present it on a very special molecule called MHC2 molecules. So now here's going to be a piece on that MHC2 complex. I'm going to have a piece of that bacteria right there. Now what happens is this macrophage, now that it's been primed with all of these bacteria, and you're going to have tons of them because lots of bacterial translocation are occurring, it's going to take this and present it to a very special cell. And this is called a T cell. And it's a naive one, right? And so the naive T cell has a very special type of protein that recognizes the antigen, and then it has another protein that recognizes the MHC2 protein. This right here is called the T cell receptor, and this is called the CD4 positive protein. Okay, now once this interaction occurs, something really interesting happens. This macrophage will become activated from this interaction here, and it'll start secreting some cytokines, which includes interleukin 1 and TNF alpha. So this is some of the things that it'll start releasing. And this is a nasty pro-inflammatory cytokines. Now, you know what else happens? The macrophage, depending upon kind of the inflammatory process here, not only release these cytokines, which we're going to talk about, it causes a lot of inflammation, but it also releases something else. It can release a molecule called interleukin 12. Now, interleukin 12, when it acts on these T cells, it converts some of these T cells into a very special type of T cell. You know, interleukin 12 is a very strong stimulator in converting these naive T cells into what's called T helper 1 cells. And T helper 1 cells, when they're stimulated, they release a massive amount of interleukin 1, interleukin 6, tumor necrotic factor alpha. And these are massive inflammatory cytokines. So now you have all of these massive inflammatory cytokines of interleukin 1, interleukin 6, tumor necrotic factor alpha. What the heck do these things do? They do so much, unfortunately. What they're going to start doing is these cytokines they're going to start activating other nearby immune system cells to come to the area, right? So you're going to start activating what kind of cells? Well, first off, they're going to get over here to the area of the bloodstream. So it's kind of like bring these guys down here. They're going to act on the actual blood vessels within the vicinity. Okay, so they're going to act on the blood vessels within the vicinity here. When they do, first thing they're going to do is going to cause these blood vessels to become very leaky. So they're going to cause the blood vessels to become super leaky. As the blood vessels become super leaky, what happens? Well, the whole purpose of making it leaky is so that any white blood cells or any kind of complement proteins that are moving through this area can leak out. So it's going to cause a lot of capillary permeability. So that's the first thing that happens. The first thing that happens with this is that you'll have an increase in capillary permeability. And that can lead to a lot of edema within the gut wall, right? So as you have lots of fluid leaking out into this area within the, again, this is within the actual intestinal wall, this is going to cause a lot of edema. So you're going to get a lot of edema associated with this increase in capillary permeability. All right, if you go back to our immunology, not only do these kind of cytokines cause increase in capillary permeability, but you know other white blood cells that are moving through this area. You'll have T cells moving through this area. You'll have other macrophages that are moving through this area. You'll have neutrophils that are coming through this area. You're going to want to let them know where all of this inflammation is. These are like little cookie crumbs for the macrophages and the neutrophils and the T cells to follow. And so another thing that it'll do is it'll stimulate these guys to come to the area of the gut wall where there's a lot of this inflammatory cytokine production. What's this called? Positive chemotaxis. So it'll try to bring these actual white blood cells towards that area. Now, in order to do that, what we need to happen is it's going to have to make some of these molecules on the vascular endothelial cells really sticky. Because what we want is we want the white blood cells to come fast through the area, but we want them to stick to the area where there's the most inflammation. So that when they stick here, they're like, oh, this is where I gotta go? All right, cool. I'm gonna go into this area. So the next thing that it's gonna do is it's going to increase the expression. Let's make it another color. Let's do purple. It's gonna increase the expression of a ton of different cell adhesion molecules within this vicinity. So in this vicinity, there's gonna be tons of these cell adhesion molecules. Now, naturally, what happens is on these white blood cells, they have very specific proteins called integrins that bind with these cell adhesion molecules. So what's going to happen is you're going to increase the expression of these CAMs, and whenever you increase the expression of the CAMs, the white blood cells have integrins that stick with it and cause the white blood cell to stick and roll along the actual blood vessel. What is that called? Margination. So not only will it cause kind of a chemotactic response, but it also cause margination. Okay, and I want you to remember here, CAMs. Okay, that's where the cell adhesion molecules are produced. So you're having a lot of interaction here. So let's draw kind of that macrophage or neutrophil or whatever. It's kind of sticking with this area here. And believe it or not, I know this seems like why the heck am I talking about this? It's actually a very important process, especially when we get into the pharmacology. This will stick here. Now that it sticks here, it'll come to this area and move via the diapedesis process into this area. and start causing more cytokine and more inflammatory damage. So this will bring more white blood cells to the area. There's one more thing though. Guess what? All these cytokines, they get into the blood. Interleukin 6, TNF alpha seem to be the big predators, and even a little bit of interleukin 1. These go throughout the bloodstream and start causing systemic complications. So you're going to get a ton of these molecules, and they're going to start rolling out into the peripheral tissues, affecting the brain, affecting the skin, affecting the joints, affecting multiple different areas and causing systemic complications. What we're talking about now is just local. Now, not only do you get this kind of effect here, okay, but these cytokines, not only do they cause lots of edema, not only do they cause a lot of neutrophil migration, a lot of macrophage migration, but you know what else? If lots of these neutrophils, so let's say that we get lots of neutrophils coming to the area, lots of neutrophils and lots of macrophages coming into the area from all of these cytokines. What's the problematic issue here? Well, you know what else the macrophages do and the neutrophils do? They release very special types of molecules that are, the whole point is that there's some type of infectious pathogen or something that's crossing over, causing this whole reaction. I don't want it here. So I'm going to release some nasty molecules to kind of destroy it. And so unfortunately, this leads to the production of reactive oxygen species, the production of proteases, and you know what this does? It tries to destroy some of the actual pathogens or whatever that form of invader is, but it starts leading to destruction of nearby tissue within the GI wall. And so this increase in reactive oxygen species and increase in proteases inadvertently leads to a lot more damage to the actual gastrointestinal tract wall. It's a problematic issue. Believe it or not, I wish we were done, but that's not it. So we got this interleukin 12. There's another cytokine that the macrophage releases. It releases another cytokine, and believe it or not, this is it's not a super well-known process. We talked about it a little bit called the Th17 cells. It releases a cytokine called interleukin 23. And what interleukin 23 does is it takes this actual naive T cell and converts this into another type of T cell called a T helper 17 cell. T helper 17 cells have been shown that when they're stimulated, normally these maintain a good regulation, kind of helping to maintain a good balance, kind of a regulatory function, if you will, of the GI tract wall within that kind of an immune system area. But whenever it's hyperstimulated by this interleukin 23, it causes this mass production of interleukin 17. You know what interleukin 17 does? It gets into the bloodstream and it stimulates a very, very specific type of white blood cell to come to the area via the chemotaxis and migration process. You know what that's called? Neutrophils. And the neutrophils in this vicinity will start secreting lots of reactive oxygen species and lots of proteases. You know what these things start doing? They start causing damage to the actual GI tract wall, damaging the Paneth cells, damaging the goblet cells, damaging the intestinal epithelial cells, damaging some of the submucosa, the muscularis externa, damaging all of the tissue within the GI tract wall. And this is problematic. Okay. Now, that's kind of the basic thing that I want you guys to remember about this. Okay? Now, the only other thing that I want you guys to think about here is that not only is all of this kind of inflammation occurring and it's really damaging all of this tissue area, again, this is the local effect. So this is that local effect. Don't forget, a lot of these cytokines get into the bloodstream and spread to multiple different areas within the body. And when they do, they cause a systemic effect. And this is some of the things that you can see that are really, really negative. Okay? So I think this kind of gives us at least the basic idea of Crohn's disease and how all of these causes and pathophysiology are related here. And the reason why I went into a lot of this detail, I know it seems crazy, is because a lot of the actual medications that we utilize particularly work in certain steps here, and we'll talk about that. All right, so this covers all of the aspects of particularly like the causes and some of the pathophysiology. Let's see how all of this damage to the GI tract wall and systemic effect leads to the clinical features that we can actually see present to us in the clinic or in the hospital or wherever it may be. All right, so we have an understanding now about some of the causes and some of the pathophysiology behind Crohn's disease, right? We know it's this massive inflammatory reaction characterized by a massive increase in, what is the big ones? Tumor necrotic factor alpha, interleukin 6, interleukin 17 are some of those big ones. And they cause lots of inflammation. Now it could be local and it could be systemic. Now the local effects within the GIT is very interesting. Now remember what I told you. Crohn's disease can occur where? Anywhere along the GI tract. It can hit the esophagus. It can hit the oral cavity. It can hit the stomach, the small intestine, large intestine. It typically spares the rectum, the anus, but it still can involve the anus, okay? So, big thing I need you to know is that this can involve anywhere along GI tract, okay? Anywhere along the GIT. Now, how does this actually occur? Well, you know what actually happens is, let's say that you get some inflammation here in the stomach and you get some destruction, some inflammatory release, a lot of cytokines, a lot of edema, a lot of reactive oxygen species and proteases, and you start causing destruction of the GI wall tissue. You can get these ulcers, okay? You can start getting these ulcers that occur at kind of like normal, like intervals of normal tissue, then destructive tissue, and then you have normal tissue, then you have destructive tissue. This is really important. Okay, so you can get these ulcerations that can occur along the GI tract wall. And usually the most common location that I really want you guys to remember tends to be the ileum. So the most common locations is the ileum and the colon in general. But for the most part, it usually spares the anus. Okay? Now, what's the issue with having all of these ulcerative lesions of the GI tract wall? Because you know it actually involves what's called transmural. You know within the GI tract wall, we'll talk about a little bit later, you have the mucosa, submucosa, muscularis externa, and then depending upon the organ, adventitia or serosa. Crohn's disease can involve all of those layers. It can lead to an ulcerative or destructive lesions of the mucosa, submucosa, muscularis externa, all the way down to the serosa or adventitia. If that happens, let's say that I destroy parts of the small intestine, because again, it can occur anywhere along the GI tract. I get some lesions here of the small intestine. You know, our small intestine is super important for absorption. If I have loss of epithelial cells that are needed to be able to absorb specific types of amino acids and carbohydrates and fats and vitamins, I lose that. So I may have a decrease in absorption. And the problem with that is if it's a decreased absorption of nutrients, right? Fats, proteins, carbohydrates. What's that going to lead to? It's going to lead to weight loss, failure to thrive, cachectic kind of appearance, right? So this can lead to weight loss and, worst case scenario, in a baby or a younger individual, a failure to thrive. Okay? That's one thing. The other thing is it's important for absorbing very specific like micronutrients. You know, things like iron or things like B12 are very important. If we lose the ability to absorb these things, right? So we have a decrease in iron absorption, a decrease in B12 absorption. This can lead to, what is iron really needed for? For being incorporated with hemoglobin within our red blood cells. If you have a reduction in iron absorption, you have a reduction in the amount of iron within the hemoglobin, and this causes the red blood cells to be smaller. What is this called? This can lead to a microcytic anemia. If you have a reduction in B12, and there's another vitamin that gets absorbed within the ileum called B9, folate. These are important for the maturation of the red blood cells. And if there's a decrease in these, you can have what's called big red blood cells, called macrocytic anemia. Here's where it's a really important thing. If you have destruction, so let's extend this down here. If you have destruction of the actual small intestine, particularly near the ileum, the ileum is really important for absorbing fats and for absorbing bile salts, okay? If there is a decrease in fat absorption, that means that you have less free fatty acids in the bloodstream, right? Less free fatty acids within the bloodstream then, because you're not absorbing as much fat. All right, so what's the problematic issue with having less fat being absorbed and having like less free fatty acids in the bloodstream? That may sound like a good thing, right? Well, not necessarily when it comes to this next problematic issue. With these fats, right? So let's say that we have kind of some fat molecules here. So here's our fat molecules. Normally, these are not bound to anything specific. Normally you have something else. You know, with inside our GIT, we may have this molecule called oxalate. All right, this is called oxalate. And oxalate is normally bound to a molecule called calcium. So normally calcium will be bound with the oxalate, okay? What happens though is because you absorb less of this fat, more of the fat stays within the GIT lumen. And what happens is instead of the calcium binding with the oxalate, it goes and it binds with the fat molecules. And as you bind lots of these calcium molecules with the fat, you lose some of the calcium with the oxalate. And so you absorb tons and tons of oxalate instead of having calcium combined with it. What's the problematic issue with that? Let me explain. Less free fatty acids within the GI lumen, you absorb, less calcium is absorbed, but as kind of a problematic kind of side effect from this, because the calcium is no longer binding with the oxalate, you absorb a ton of oxalate. That oxalate, believe it or not, can precipitate and form nasty crystals. And you know where these crystals can really kind of precipitate and get stuck? They can get stuck in a very, very special organ that helps us to make pee-pee, called the kidney. And as a result, you can get these oxalate stones. And so what's the result of this? The result of this is that you can increase the risk of what's called kidney stones, okay? So there's an increased risk of kidney stones, also known as urolithiasis in this case. What else do we have less absorption of? So not only is there malabsorption of like nutrients, not malabsorption of micronutrients, and malabsorption of fat, which plays a role within the formation of kidney stones, but also less bile salts. So you have less bile salts. You know, bile salts are very important within our gallbladder with making bile. It's obviously one of the most important components of bile is the bile salts, the cholic acid, the deoxycholic acid. Whenever you have less bile salts, right, this becomes a problematic issue with the bile. Now the bile is going to be rich in what? Less bile salts. What's the other main component of the actual bile? Cholesterol and fat. But cholesterol seems to be the big one. So now in this bile composition, you're going to have less bile salts because you know these bile salts, they get actually absorbed across the ileum, taken back to the liver, recycled, and get put back into the bile. If you have less of them getting absorbed, you have less bile salts to put into the bile. Instead, you have high cholesterol. This high cholesterol and low bile salts leads to what's called gallstones. So then you start getting what's called gallstones. And if we were to kind of show that here, what is this called? What's the actual technical name for gallstones? This is called cholelithiasis. So this is called cholelithiasis. So again, it's going to increase the risk of what's forming gallstones via cholelithiasis due to less bile salts being absorbed, or lead to the increased risk of kidney stones due to increase in oxalate absorption, and also anemias due to less B12, less B9, less iron, and also weight loss and failure to thrive due to just decreased in macronutrient absorption in general. All right, let's now talk about diarrhea. All right, so now if we have the next thing, which is diarrhea, again, you're going back here to like, let's say large intestine. So small intestine was very specific for the malabsorption. But again, Crohn's disease can involve anywhere along the GI tract. Let's say that you get some ulcerative lesions along the actual large intestine. If you get this, what's the large intestine really good for? Don't say absolutely nothing. The large intestine is good for absorbing some electrolytes, but primarily water. So it's primarily involved in water absorption within the large intestine. So again, let's kind of annotate here. This is within the large intestine, okay? If there's ulcerative lesions within the large intestine, you have less epithelial cells there, less of these simple columnar cells to be able to absorb the water because they've been damaged. There's a loss within that normal barrier. You have less water absorption. If you're absorbing less water, that means all of that water is going to stay within the GIT. And when you go ahead and restock the lake with brown trout, you go ahead and drop the deuce, what are you going to be dropping out with it? Tons of water. And so this can lead to a lot of water being lost within the stool. And if you get got the Hershey squirts or you're peeing out your butthole, this would be diarrhea as a result of destruction of ulcerative lesions of the large intestine leading to less water absorption. So let's say that you get a lot of these ulcerative lesions of the intestines, whether it be large intestine, small intestine, doesn't really matter. You get these ulcerative lesions, right? Now, naturally, what happens is we know that not only do you get these ulcerative lesions, but you get tons of inflammation within that wall, right? There's going to be lots of interleukin 1, interleukin 6, TNF alpha, lots of white blood cells, lots of fluid. There should just be naturally a ton of edema. So there's going to be like a thickening and edema of the actual walls. So what could I see here? Not just would I see some ulcerative lesions, but you know what else I could see? I may also see a lot of edema and bowel wall thickening. So now I'm going to have some bowel wall thickening. And within that bowel wall thickening, I'm going to have lots of fluid and white blood cells, inflammatory products there. And you know what else can start happening? You can also start activating fibroblasts in the more chronic stages of the disease. So then you start getting a little bit of fibrosis, some scarring of these actual areas of bowel wall thickening and edema and where the actual ulcerations are. But if you look here, what happens if you got to try to move poop through this area? If I try to move poo-poo right through this area, it's narrowed. Then there's a little bit of an area of kind of like some ulcerative lesions, but then I got to go through another narrowed area. This narrowed area due to the bowel wall thickening and inflammation and maybe even some type of fibrosis is called strictures. And these strictures can reduce the passage of fecal matter through the actual bowels. And what can happen as a result of that? What happens if I'm not able to push a big enough turd through that area? It gets stuck proximal to that. And so then what happens to that? All that poop starts getting stuck and it starts expanding the bowel walls proximal to this. It kind of mimics somewhat of a bowel obstruction. So strictures increase the risk of bowel obstructions. Okay. All right, so far at this point, we've already understood that Crohn's disease can involve any part of the GI tract, right? Ileum, colon. It can even involve the oral cavity. Aphthous ulcers is sometimes a common manifestation. We talked about how it can cause malabsorptive syndromes. It can cause watery diarrhea. It can cause strictures leading to increased risk of bowel obstructions. What else can it do, though? Another thing that I want you guys to remember is because you can get these, again, what kind of inflammation? A transmural, right? Which means it goes through almost all the layers of the GI tract wall. So it'll involve the mucosa, the submucosa, the muscularis externa, and maybe even extend down to the serosa. And organs that have serosa, which means it's an intraperitoneal organ, it's inside of the peritoneum, it has a visceral and a parietal peritoneal layer. In these, sometimes what can happen is the ulcer can actually extend through the serosa, and then epithelial cells can actually migrate and form somewhat of this like epithelial tube, if you will. And this epithelial tube can connect to nearby organs. This connection between the GI tract and a nearby organ is called a fistula. Okay, so it's basically whenever the inflammation of the ulcers have eroded all the way down to the serosa and some of the epithelial cells migrate and make an epithelial tube that connects to organs. What organs can it connect to? One of the big ones is it connects to the skin, and you can literally have like GI material coming out from the GI tract that connects to a fistula and drains fecal material onto the skin. This is called a enterocutaneous fistula. You can also have this, especially the rectum, near the rectal areas, near two structures, the bladder and the vagina. So nearby, you can actually fistulize and have some of those structures connect to the actual bladder. And what is this called? Another word for the bladder is the vesicle. So we have what's called enterovesical fistula. Then if it actually connects to the vagina, which is usually the rectum, kind of fistulizing with the vagina, this is called a rectovaginal fistula. And so if someone has enterocutaneous fistulas, obviously there's going to be fecal material that's escaping onto the skin. Enterovesical, you know what this causes? This causes fecal matter to present inside of the actual urine. So there can be tons of bacteriuria and fecaliuria, but also sometimes there's lots of gas that can present within the vagina. Within the urethra and within the urine. And so this can cause pneumaturia. But this definitely increased the risk of them developing urinary tract infections. So you can have lots of bacteria that show up within the urine, within the bladder, as well as pneumaturia, which is kind of gas within inside of the urine. Then again, rectovaginal, you'd obviously have fecal material coming out through the vagina. That sounds absolutely disgusting, but it's possible, right? The next one is that you can fistulize between one part of the intestine to another part of the intestine. And if you do that, that's called a enteric fistula. Okay? Now these fistulas, one of the problematic issues with these is, think about this. If you have an erosion, it extends all the way down, right? It extends all the way down to the serosal layer, and then you start developing this epithelial kind of tube nearby. The bacteria that is present within inside of the GI tract can then do what? Can just invade through that fistula into nearby tissues and cause infections, or it can accumulate in this area and become walled off. What's that called? I'm glad you asked. It can become an abscess. And so again, sometimes what can happen is, whether it just be due to the transmural inflammation or whether it be due to the fistulas, you can develop pyogenic complications. Where, let's say here, you have a opening up, there's this transmural inflammation ulceration of the GI tract wall, and now bacteria can just completely invade right into this little area here. So now you have an opportunity for infectious pathogens to extend into this area of where the transmural inflammation and ulcers were and lead to an infection. What is this called? An abscess. And usually these abscesses occur commonly near the perianal area. So perianal abscess is a relatively common type of abscess, as you can see within Crohn's disease. So we have GIT involvement anywhere along the GI tract. Usually it spares the anus, but it can happen in the anus, obviously, in perianal diseases. Again, we can get malabsorptive syndromes, we can get diarrhea, we can get strictures with increased risk of bowel obstruction, fistulas. What kind? Enterocutaneous, enteroenteric, enterovesicular, and rectovaginal. And then also you can develop pyogenic complications called abscesses. And these abscesses, what kind of pathogens would be kind of invading into this area? Anything within our GIT, right? So you're going to see kind of anaerobes and lots of gram-negative bacteria that is going to be infiltrating into this area, and that's important to remember. The other thing I want you guys to remember, going along with diarrhea, is that if you actually have ulcerations, if you actually do have ulcerations of this kind of like bowel wall, where the small blood vessels that are moving through the actual vessel within the GI tract wall, if there's enough inflammation and ulceration that it actually hits one of those small little vessels, you can lead to small amounts of blood to end up with inside of the stool. And so sometimes there can be red blood cells that show up within the stool, but it's not an overt kind of GI bleed. It's something that may come up positive when you do like a fecal occult blood test, or it shows up kind of insidiously with someone having signs of anemia. So that's another thing to remember, is that again, with the diarrhea, I wanted you guys to make sure it's primarily watery diarrhea, but there could be red blood cells that leak into it in cases where it actually erodes into the small vessels within the GI tract wall. Okay, good. So we have malabsorption involving small intestine, diarrhea involving large intestine with possible red blood cells. We got strictures with increased risk of bowel obstruction, fistulas, abscesses. What's another complication GI-wise, locally? Well, think about this. If I have the epithelial cells and all the other tissue cells, here's the ulceration, right? Generally, what's going to happen? You have tissue destruction. Normally, your GI tract cells, they have the ability to replicate. They have the ability to undergo mitosis. They're not amitotic. And so what will happen is, if you salvage some of the cells which are nearby the basement membrane, they'll try to go and repair this area and replicate. But then let's say that you destroy it again. You have another flare-up. So then let's say on top of that you have another flare. So there's another flare. You destroy more tissue cells. After you destroy those tissue cells, more cells try to come in and replicate and try to fix that area up. And you just have this continuous type of process. So with multiple flares and increased replication and healing, what happens if you have tons and tons and tons of DNA replication? There's always the risk of having a mutation. There's always a chance of having some type of problematic issue with the DNA replication process that increases the risk of mutations, therefore leading to cancer. So there is an increased risk of mutation risk with multiple replication cycles, and that can increase the risk of colorectal cancer. So that's a big thing to be able to think about, okay? All right, so we covered the local complications of someone with Crohn's disease. Now let's cover some of the systemic involvements of Crohn's disease. All right, so now let's talk about the systemic complications of someone with Crohn's disease. Again, this is a massive and kind of inflammatory condition, right? So not only is it involving the GI tract wall, but it can extend outwards and involve multiple systemic areas. So what if you have this massive cytokine release? Remember, interleukin 1, interleukin 6, tumor necrotic factor alpha, interleukin 17, all of those guys are released. Interleukin 17 kind of has its effect mainly within the GI tract wall, but interleukin 6, interleukin 1, TNF alpha, they cause this cytokine storm, if you will, that kind of affects the hypothalamus. So if you cause the hypothalamus to become stimulated, it increases the release of what's called PGE2, and this increases your body temperature. What can this lead to? This can lead to fever. So that could be one obvious sign, is that a patient may have fever. That's not indicative of an infection, it's just indicative of the giant inflammatory process that they have going on. Now, the other thing that you definitely have to remember, we'll take a picture, take a look at these, is it can involve the actual eye and particular parts of the eye. So you know you have the choroid, which is this red part here, and then you have this is the iris, this is the choroid, and then you also have the retina there. Now, you also have another tissue here called the sclera, okay? Now, what happens is this inflammatory process, you lead to lots of cytokines and inflammatory cells that infiltrate these areas of the choroid, the iris, the retina, and the sclera. If it involves kind of the episclera, so it's a tissue just on top of the sclera with a lot of vascular supply to it, it can cause episcleritis. Okay, episcleritis. If it involves the anterior aspect, you know the uvea? The uvea is kind of, there's two parts of it. The anterior aspect of the uvea, which primarily is made up of the iris, and then the posterior, which is kind of the choroid and the retina. If you involve that portion just of the iris, that's kind of the anterior aspect of it. We call that iritis or anterior uveitis. We'll just put iritis. And then the next thing is if you involve the posterior aspect of the uvula, which is the choroid or the retina, this is called posterior uveitis. So you may see anterior uveitis, or also known as iritis, or you may see posterior uveitis, which is involving the choroid and the retina, or episcleritis. We'll take a picture of those and take a look at them. All right. The next thing is if there's a massive inflammatory cytokines that involve the skin. It can lead to some really nasty lesions. So you know within the skin there's one condition called erythema nodosum. And one more which you definitely have to remember, which is called pyoderma gangrenosum. This is a really interesting type of lesion, and you really want to remember this to be kind of on extensor surfaces. So if you see this on particular extensor surfaces, this is a big thing to remember. The next thing that I want you guys to remember is that if the inflammation extends and it starts causing inflammation of particular areas of the bones and the joints, especially near the sacroiliac area and near the spine. If you cause inflammation of the actual vertebral column in that area, it's called spondylitis. So you may see signs of what's called spondylitis, or you involve the sacroiliac joint and cause inflammation of the sacroiliac joint. This is called sacroiliitis. And you know what's interesting about this? You can have also peripheral joints can be involved as well. But whenever you see these like spondylitis and you see sacroiliitis, this should make you think of HLA-B27 positive types of conditions. These are called your seronegative spondylarthropathies. So this would make you think of like ankylosing spondylitis, reactive arthritis, and IBD or enterohepatic arthritis. So in conditions like IBD, they can present within these HLA-B27 or seronegative spondylarthropathies. So they may have pain within the vertebral column or pain around the sacroiliac joint, decreased kind of mobility around that area, and then also maybe some peripheral joint involvement. Okay, that's a big thing to remember. The next one here, as if we come down, it also can lead to involvement of the parts of the liver. You know, there's inflammation, and this inflammation starts extending to the biliary ducts. So you can actually kind of get inflammation around the biliary ducts with inside the liver called intrahepatic, or the biliary ducts outside the liver called extrahepatic biliary ducts. This inflammation of these biliary ducts due to the cytokines is called primary sclerosing cholangitis. Okay, now, big thing to remember here with the primary sclerosing cholangitis is it is an inflammatory type of reaction, particularly of the intrahepatic and extrahepatic biliary ducts. You know what's really important though, and I want you to remember, because again, we're going to talk about UC, ulcerative colitis. This seems to be more common in ulcerative colitis than it is in Crohn's. That's an important thing to remember. Okay? Now, the next thing that I want you guys to think about is because of this massive inflammatory cytokine storm, you know we have different types of proteins that are present within inside of our blood vessels that are running through, that are involved in helping to make clots. So you have what's called the procoagulants, right? And what happens is there's a very specific type of protein, very, very specific type of protein. You know there's a protein called von Willebrand's factor? Von Willebrand's factor basically is this protein that kind of gets deposited. Let's say that there's like a micro tear within the blood vessel. Okay, you get a little micro tear. Generally, there's this like little protein here called von Willebrand's factor, and it activates platelets. And the platelets want to come there and stick. So if I had a ton of like little platelets, the platelets would come here and stick to this area and cause a big old clot. And this can occur within an artery or it can occur within a vein. What happens in these patients due to these like increased cytokines is it may increase the activity of some of the procoagulant enzymes, but also increase the activity of the von Willebrand factor. If you increase the activity of some of these procoagulant enzymes, you increase the formation of clots easier, but also you increase the initiation of clots easier. And so this can lead to arterial thrombi, or you may jack up them veins, man. And if you jack up them veins and you get clots within them, that may lead to venous thrombi. So these are big things to remember as well. It's more commonly that you'll see the involvement of the venous thrombi than you will of the arterial thrombi. So you may see patients with DVTs or PEs as a complication of the Crohn's disease. Okay, so we got all of these systemic involvements in Crohn's disease. Now let's go ahead and move ourselves over to the diagnosis of Crohn's disease. All right, so let's talk about the diagnosis of Crohn's disease, right? So we've talked about the causes, we talked about the pathophys, we went through some of the actual clinical features that may be presenting within the GI tract wall, like the local effects, the systemic effects. If you suspect someone has Crohn's disease, right? One of the other things that we didn't really talk about with the GI tract involvement, with all those ulcerations, it may produce abdominal pain. And if they do have abdominal pain, what was the most common locations that I told you guys to remember for Crohn's? The ileum and then the colon. So usually that's going to be on that right side. So they may present with more of a right lower quadrant abdominal pain. If you suspect that they have Crohn's disease, what are some labs that may help point me in the direction of Crohn's? Well, first thing is, let's say that we think, oh man, maybe there's some small intestinal involvement because they have a weight loss, they have cachectic kind of appearance, they have a decreased amount of protein on their CMP, they just look like they're having a difficulty being able to thrive, they have anemia, something like that. I'm suspecting a malabsorptive type of problem. We'll go back, think about that. If there's a decrease in the absorption of what type of things? Let's say there was a decreased absorption of proteins. If you check their actual CMP, so on a CMP, it gives you their total protein. And these patients, they might not have as much proteins that they're actually absorbing across their livers being able to utilize to make things like albumin and globulins and things like that. So if you check, they may have a decrease in their total protein that's present on their CMP. So get a CMP. If you see that they have a decreased number of albumin, a decreased number of proteins, total protein, that may be one of the things that you can think about. Sometimes also if someone's cachectic or having weight loss, they're actually utilizing or damaging their muscles, or they're not having as much protein incorporated into the muscles. So another thing that you may see besides having a decrease in proteins from malabsorption is there may be a decrease in their creatinine. Okay, and that may also be something that you can pick up off the CMP, particularly the BMP. Okay, so if you get a CMP, you may see that they have a decrease in the creatinine or also a decrease in their total protein. That may kind of key in about a malabsorptive syndrome. Now, another thing that may be a problematic issue here is that there may be a decreased absorption of iron and a decreased absorption of B12 and B9. What did I tell you about these? If there's less iron that's being absorbed, you can check iron, but more likely than not, you'll actually see someone with, if you get a CBC, they're going to have less red blood cells, but the red blood cells are going to be small. And we utilize a very particular red blood cell indices to determine if they're small red blood cells. It's called MCV, mean corpuscular volume. So if they have low red blood cells and a low MCV, you may be thinking that they have iron deficiency anemia. And you can pick that up off of their CBC. So you can get a CBC and maybe some iron studies if you really wanted to go that extra mile. So the thing I could check for this is a CBC. So I could check a CMP, I could check a CBC. Also, B12, B9, I could check those levels, but guess what? If I have a B12 and B9 deficiency because I'm not absorbing these properly, then I'm going to also result in these kind of less red blood cells and less hemoglobin, but guess what? Their mean corpuscular volume goes up. And so they have a high MCV, and that may clue you into what's called a macrocytic anemia. And again, what could I get that off of? I could get that off of a CBC, okay? And again, these are some of the things that you want to be thinking about with these kinds of patients, right? So we could be checking a lot of these things, checking to look for any kind of malabsorptive issues. Now, what else could I do? The other thing I'd want to be thinking about here is that sometimes with the liver is important because whenever there's kind of a massive inflammatory cytokines, remember those cytokines that were released again? Interleukin 6 is a big one, tumor necrotic factor, alpha, interleukin 1. These love to tell the liver, hey man, lots of inflammation going on, buddy. You better start releasing some very specific types of molecules to let people know. And this is called CRP, or there may be an increase in the CRP, the C-reactive peptide, or an increase in the erythrocyte sedimentation rate. And so these may be other things that you can see on a patient, particularly with celiac disease. Okay, so there may be an increase in CRP, there may be an increase in the ESR because of the acute phase type of reaction because of the inflammation. Okay, what else? Now, another thing that we could look at is that, whenever they have these acute phase reactive proteins, it's kind of indicative of like a systemic inflammation. We may be able to kind of narrow down the inflammation to the GI tract wall specifically. So whenever those neutrophils were coming to the area because they were being stimulated by different types of cytokines, they were being stimulated by interleukin 1, they were being stimulated by TNF alpha, they were being stimulated by interleukin 17. And when they were activated, they were releasing tons of reactive oxygen species and proteases and damaging the bowel wall. Well, you know what else they release? They release very specific types of proteins that can show up within the poo-poo. And what are these proteins that can show up within the poo? These are called fecal calprotectin. This will be positive and elevated. And another one which is called fecal lactoferrin. So you got to get your hands in that poop, send out a stool sample, and check for these particular types of inflammatory markers that are actually a little bit better than a CRP and ESR, telling us about the GI tract wall inflammation. Okay? So we can check for malabsorptive types of processes. We can check for acute phase reactive proteins of systemic inflammation, more specific inflammation of the GI tract wall. What else could I do? Now, the next thing that you could also check is, those antibodies that are sometimes, lymphocytes can get involved in this process and they can release antibodies. We didn't talk about it too much over there within that kind of immune response. And the reason why is it's more particularly in ulcerative colitis that we see these very specific antibodies. One of the specific antibodies that I want you guys to remember is called P-ANCAs. Okay, these are specifically like anti-neutrophilic cytoplasmic antibodies. Okay, and these are released and they attack neutrophils. So generally what they'll do is they'll attack neutrophils. And the theory behind this, we'll talk more about it when we get into ulcerative colitis. But P-ANCAs are more specific to ulcerative colitis. You should always check because sometimes it's tough to determine, is this UC or is this Crohn's disease? So what happens is you check a P-ANCA, and in Crohn's disease, the P-ANCA should be negative. This should be positive only in ulcerative colitis. Now, there is another test. You should know it for your exam, but the sensitivity of the test is not very good. You can check what's called the anti-Saccharomyces cerevisiae antibodies, which is like these antibodies against like the yeast, like cell wall. These ASCA antibodies are positive. But remember, they have a low sensitivity in kind of like determining, a patient having Crohn's disease. It's easier just to check to see if the P ANCAs are negative. If you check these ASK antibodies, it's kind of more of a test kind of exam question that you want to remember. Okay? All right, so we've gone through these particular tests that are more of the lab things that you'd want to do. The other things that you'd want to do is, if I'm thinking that a person has Crohn's disease and they have diarrhea, what else would I want to do? Rule out infectious causes. So I definitely would want to send off maybe a stool sample to rule out any kind of infectious diarrhea, because that also may be something that may be going on there. So also think about that. When you're ruling out, trying to figure out, is it Crohn's disease, rule out other causes by sending out some stool sample analysis and checking to make sure that there is no kind of infectious diarrhea present. Okay, let's come down. Now we're getting into the imaging. If we talk about the imaging that we really want to know for a patient with Crohn's disease, there's two types of imaging. Well, there's actually three imaging modalities that you could do. The first one that you could do, which is the gold standard, is what's called a ileocolonoscopy and biopsy. This would be kind of the best test. This is your gold standard, okay? And what could this tell me? If I do an ileocolonoscopy with biopsy, I'm going to be taking kind of this camera, running it up through their butt, up through their colon, looking at the colon, looking all the way around here, and even getting down here into the area of the ileum, and looking to see what's going on. I could see a bunch of things. I could see ulcerations in Crohn's disease. What else could I see? I may also see strictures. I may see abscesses. I may see fistulas. But you know what is a characteristic thing that you need to remember that you can pick up of an ileocolonoscopy? Is you may see these lesions that pop up where you have normal tissue, damaged tissue, normal tissue, damaged tissue. It's like you're skipping from areas of damage to normal, damage to normal. These are called skip lesions. This is a very important kind of like buzzword term that you guys need to be able to remember. Is that you may have areas of like edema, bowel wall thickening, and then areas of like ulceration. And so it kind of looks like a cobblestoning type of appearance if you look at that on the ileocolonoscopy on the camera. So it may also have what's called a cobblestone appearance. These are big buzzword terms that you need to think about for Crohn's disease. Skip lesions, areas of damage, normal, and areas of bowel wall thickening and ulcerations in between, indicative of cobblestoning of the actual mucosa. The next test that you could do, this is the ileocolonoscopy, it's the gold standard, kind of the best test that you could do. An alternative to that is you could do what's called a MRE, an MRI enterography, or you could do a CTE, which is a CT enterography. The MRE is actually the preferred test, okay, because it's way more sensitive. The only reason you would get a CTE is if a person's like unstable, they have some type of contraindication of getting an MRI. But MRE should be the preferred over CTE, way more sensitive. And what this can do is it can still tell you, is there any kind of like strictures? It can tell you if there's any bowel wall thickening. It can tell you if there's any kinds of like complications like fistulas, abscesses, strictures, anything like that. It's really good at that. But it also picks up one other thing. Sometimes you can get like this mesenteric fat that you get a ton of. And it's like this excessive mesenteric fat that can occur around the actual bowel wall. And you know what they call this? It's called the creeping fat sign. It's called the creeping fat sign. And this is when they have excessive mesenteric fat stranding that occurs around this inflamed GI tract wall. And that can be easily picked up on a MRE or CTE. So ileocolonoscopy, to get a good camera visual look inside of the lumen, you can pick up skip lesions and cobblestone. You can actually look at the mucosa. With an MRE, you can't visibly see the mucosa, but you can pick up some subtle signs of some of the same things, complications like abscesses, strictures, maybe some areas of bowel wall thickening, maybe even certain types of like abscesses or strictures and things like that. But another big thing that you can see is this, what's called excessive mesenteric fat stranding around the bowel wall edema, and that's called creeping fat sign. The last test that you could do, and it's actually kind of working its way out in efficacy and they don't use it too much anymore, But this last test that you could perform is called a small bowel follow-through. So the next one is called a small bowel follow-through. And what you do is, it's an x-ray. You have them swallow contrast and you take pictures as the contrast is moving through their actual GI tract, okay? And what happens is, if you have an area, let's say right here, you have some contrast that should be flowing through this area right here. It will flow through this portion that's maybe a lot thicker, but it'll be really thin through this area. And so it looks like a string is like moving through that area of that stricture. And so it's really good at picking up a very specific type of buzzword term called a string sign, which is kind of an area of significant stenosis or stricturing of the actual bowel wall due to the Crohn's disease and having a lot of that inflammation. So these are the big things that I need you guys to remember. So first test, gold standard, ileocolonoscopy, get a biopsy, because if you biopsy these areas of ulcerations or cobblestoning, all that stuff, you want to look at it underneath a microscope for the pathology of it. Then, if you can't get that, MRE is the second test. Good at picking up a lot of the same things, but doesn't get a visual look at the colonic mucosa. And then the last test, which is probably the least effective test and not commonly utilized anymore, which is the small bowel follow-through. Other tests that you could do is you could do like the pill camera. It's very expensive and it takes a long time, but that's another option that you could go to for these imaging. Okay, nonetheless, we do these tests. We think that they have Crohn's disease. We see the cobblestoning. We see the skip lesions. Let's say we get the MRE. We see the same kind of thing process here. Ulcerations, bowel wall thickening, complications. We see the creeping fat sign. We get the small bowel follow-through. We see the string sign. When we get the biopsy, there's an important thing that I want you guys to remember. Now go back to your histology, right? You have the mucosa. And what's the mucosa made up of? You have your epithelial cells, you have your purple layer here called the lamina propria, and then you have that little muscle layer there called the muscularis mucosa. That's part of your mucosa layer, right? Then underneath that you have this blue layer, and this is called the submucosa, right? That's called the submucosa. And then you have another layer here, which is just this red layer. That red layer there, we're going to abbreviate it, it's called the muscularis externa. And then the last layer is this pink layer, which can actually be two things. It can either be adventitia or it could be serosa. So it's either one of those, and it depends upon which part of the organ you're in. If you're in a retroperitoneal organ, it'll be adventitia. If you're within an intraperitoneal organ, it'll be serosa. Either way, when someone has Crohn's disease, they get all that inflammation, all those cytokines, all that kind of cellular damage and reactive oxygen species and proteases. It destroys all the way down here. It destroys through the mucosa, the submucosa, the muscularis externa, and extends down here into even the serosa or adventitia. This right here is called transmural inflammation or transmural ulceration. This is a microscopic finding that you would see. So if you took and biopsied this area of ulceration and you looked at it underneath the microscope, this is another big thing to look at, microscopic examination, right? So you're looking at this under the microscope. You would see transmural inflammation or ulcerations involving all of these layers here. You know what else you see? You know, within the bowel wall, because of all those inflammatory cells that are kind of aggregating to the area, remember I told you that whenever there was all those immune system cells that were coming to the area, what were those immune system cells that we had? What were these blue cells here? These were called your macrophages, and there was tons of these, right? And then what were the other cells that they were interacting with and pulling lots of those cells into the area? T cells. Right? So you had your T cells, your different types of lymphocytes. Then after that, you may have also these like necrotic, not necrotic area, but all these like proteins and giant cells that accumulate here in the center here. So there may be what's called these giant cells, which are kind of like some of the macrophages that are fusing together and some of the proteins within there. You know, the asteroid bodies, the shaman bodies. We talked about that in the video called sarcoidosis. Similar thing here. But there's another thing, which is some of these fibroblasts come to the area and form some of this fibrotic tissue around there. So you're also going to have some like fibroblasts and some connective tissue surrounding that. This structure here is called a granuloma. It's kind of an accumulation of proteins in giant cells, then macrophages, then lymphocytes, then fibroblasts with connective tissue. But the center of this granuloma does not contain necrotic or dead tissue. So this is very, very specific finding that you want to remember, called a non-caseating granuloma. So what would happen is if you were to kind of take an actual a biopsy of this area of the GI tract wall where there's like ulcerations and inflammation and bowel wall thickening, and you looked at it under the microscope, not only would you be able to see these areas of transmural inflammation, ulceration, but you may see nearby these non-caseating granulomas. And that's another very, very important finding here that you want to be thinking about, is these non-caseating granulomas that can appear up on the microscopic imaging. We've covered all the aspects of the diagnostics of Crohn's disease. Now let's talk about the treatment of Crohn's disease. All right, so let's talk about the treatment of Crohn's disease. When we talk about treating Crohn's disease, one of the big things that you want to be thinking about is, what are we trying to target? So primarily, Crohn's disease is medically mediated, all right? There's specific types of medications that we're going to try to be able to kind of suppress their immune system. There's a lot of immunosuppressive therapy. But when we're doing immunosuppressive therapy, one of the big things is you have to understand what you're trying to accomplish. So Crohn's disease usually occurs in like flares, right? So you can have a flare-up where you have more of this kind of problematic issues that we talked about. And then they may go into a period of remission where they have none of these autoimmune kind of inflammatory attacks. When someone has a flare-up, you want to be able to induce remission, stop the flare-up. But then you also have to have other medications that come through the back door and prevent any kind of relapse in the future, maintain the remission. So we have to understand that. If someone has a flare, like a Crohn's flare, we're going to want to prescribe particular medications that are going to induce remission. And the main ones that I want you guys to think about for inducing remission is corticosteroids, but also biologics, okay? And then for maintaining, once we've kind of induced remission, we want to maintain remission. And this is where we maybe continue on with the biologics, or we try other different types of things like other types of immunosuppressive medications that maybe take a little bit longer to work, but once they kick in, they're pretty strong. Okay? So the big thing I want you to remember here is when we're having a flare of Crohn's disease, we want to induce remission. Corticosteroids seem to be the best for that. And then maintaining the remission is where you're going to want to be able to utilize some of your biologics and other types of immunosuppressive therapies. Okay, so let's talk about some of these medications. The first one that I want you guys to understand or know about is what's called sulfasalazine. Sulfasalazine. So this is kind of almost like a NSAID in a way. Okay? What happens is you take sulfasalazine as like a pill. You can also give it like rectally. But you take this, and when you take sulfasalazine, it gets broken down into two different parts. The main part that I want you to know that it gets broken down into is what's called 5-ASA. Okay? This 5-aminosalicylic acid that it gets broken down into is going to act somewhat like aspirin. And so since it acts like that, you know what it does? Whenever there's like lots of tissue damage, there's like lots of tissue damage here of the GI tract wall because of Crohn's disease, there's lots of damage here. Lots of damage of tissue cells. There's a molecule called arachidonic acid. It's a part of the cell membrane. It gets broken down. And when it gets broken down, it goes through this process where, let's say you have some tissue damage here. When you have this tissue damage, you release out some arachidonic acid, and then arachidonic acid will get converted into what's called prostaglandins and leukotrienes. Those prostaglandins and leukotrienes, you know what these sons of guns like to do? They like to tell the macrophages, hey man, lots of inflammation going on around this area, bro. You gotta take care of it, bro. You need to start stopping this kind of, what are you gonna do, man? So he starts releasing things like interleukin-1, tumor necrotic factor alpha, and interleukin-6, which kind of induces that massive kind of inflammatory response, right? And whenever this is released, this is going to induce that massive inflammation, which pulls more macrophages into the area, more neutrophils into the area, more lymphocytes, causes more edema, more reactive oxygen species, proteases, and tissue destruction. So what sulfasalazine does is it gets broken down into two components. One is like the sulfapyridine, which is the side effect portion, and then the 5-ASA. 5-ASA will work specifically on a very special enzyme that triggers this process of going like from arachidonic acid into prostaglandins. You know what this enzyme is called? Keep your minds clear. It's called COX, right? It's COX. Cyclooxygenase. Cyclooxygenase works in this step here to be able to drive this process. 5-ASA is a cyclooxygenase kind of inhibitor. And what it'll do is it'll inhibit this enzyme. If you inhibit this COX enzyme, it can't convert the arachidonic acid into the prostaglandins. That results in a decrease in the prostaglandin leukotrienes. That results in a decrease in the activation of these macrophages and results in a decrease in these massive cytokine storm that reduces a lot of the edema, the inflammation of that bowel wall area. So this is one of the medications that we can prescribe. Usually, sulfasalazine is more for the mild cases, okay? And we prefer it maybe in a patient that we're trying to limit corticosteroids for. It's one of those drugs that may be helpful in inducing remission and maintaining remission, but it's not super effective. So we kind of go to other medications in that, as an option. But more in the mild states, sulfasalazine may be utilized. Okay, the next thing that I want to talk about here, before we actually keep going on with all these other medications for immunosuppression, is remember I told you, this is kind of an interesting thing here with Crohn's disease. Crohn's disease is definitely a lot of inflammation, right? Lots of bacteria that may be either translocating or accumulating within inside of the GI tract lumen. But there's also complications. You know how they can get fistulas? And the fistulas can maybe lead to some pyogenic complications. So they may end up having what's called fistulas, which can maybe lead to some pyogenic complications, or they have things like abscesses due to the transmural inflammation, ulcers, and the bacteria just infiltrating into these areas, right? When that happens, these are pyogenic complications. This is an infectious process on top of their already problematic Crohn's disease. And these types of pyogenic complications, you would actually treat these with antibiotics. Okay, so we would do antibiotics. You know what kind of antibiotics we'd have to target? Well, think about it. I talked about over there, we had what kind of bacteria? Gram-negative bacteria, but what were the other big ones? Anaerobes. Anaerobic bacteria, we want to target with metronidazole. Okay, so metronidazole. We also can use another drug, another oral drug. You know another oral drug that actually targets anaerobes? Augmentin. What's the actual generic name for Augmentin, though, if we were to be specific? It's amoxicillin and clavulanic acid, right? So if we were to really be specific, it's amoxicillin and clavulanic acid. But we're going to just say Augmentin. And another time that you can use this, because it's a really broad spectrum, it covers some anaerobes and also gram-negative bacteria, is fluoroquinolones. Augmentin can also cover gram-negative bacteria as well. Metronidazole is more specific, though, for the anaerobes. Your Augmentin can give you some anaerobes and gram-negative coverage, but the fluoroquinolones is a very kind of broad spectrum type of antibiotic as well. Now, the other thing that's really interesting, and there's still not enough research on it, but they're saying that maybe these antibiotics, not only are they good for the pyogenic complications, but these antibiotics maybe have some anti-inflammatory effect in Crohn's disease. And in some way, shape, or form, they may be helpful in being able to reduce some of the inflammation associated with Crohn's disease. But this is still questionable. So stick primarily with this upper part here, that if they develop pyogenic complications, that's when you give antibiotics. Don't go straight away with some of the research still not being known yet if they have the anti-inflammatory effect. Okay, so we've covered sulfasalazine. We covered the pyogenic complications like abscesses and fistulas and things of that nature with antibiotics. What are other medications that we can prescribe? Okay, another one, this is the big mama. The big mama here that I want you guys to think about here is corticosteroids. Corticosteroids are kind of like the backbone for a patient with Crohn's disease. You want to know why? This thing covers everything. That's just why. It's such a powerful drug. It's really good at being able to induce remission during those acute flares. And so there's many different types. You can give what's called budesonide. I think this one's a really cool one. Imagine like you get a drug, right? So here's the drug. And you take the drug, you're swallowing a PO, and here's this area. Let's say here's the area of the most inflammation. When it gets to this area of the most inflammation, it releases some of the particles from the drug into this area. So it's kind of like a controlled release drug. Really interesting. But budesonide is a steroid that you can give. Another one that you can give PO is prednisone. Prednisone is another one. And then another one you can give kind of IV if you have to is methylprednisolone. All right, so either way, you give some of these corticosteroids, they're good for kind of inducing kind of the remission. They're more for more like the mild to moderate kind of cases or even severe cases. This is just a general all-around good drug. Now, how do they work exactly? Corticosteroids are very interesting kind of medication. So let's say here I have a corticosteroid drug here that you get into the body. What they do is they first love to act on these macrophages, and they also love to act on these dendritic cells. When they act on these cells here, the dendritic cells and the macrophages, you know the macrophages and the dendritic cells are antigen-presenting cells. So they're the ones that interact with those bacteria that translocate, and they release what kind of cytokines? Interleukin-1 and TNF-alpha, which cause a lot of inflammation, right? So what these corticosteroids do is they inhibit the macrophages and inhibit the antigen-presenting cells from releasing these cytokines. So it results in a reduction in these cytokines, which cause a lot of the edema and neutrophil migration and a lot of chemotaxis and a lot of inflammatory processes. The other thing this is really interesting is remember the macrophages and the dendritic cells, they release very special types of cytokines like interleukin-12 and interleukin-23. Corticosteroids also inhibit these macrophages and dendritic cells from releasing interleukin-12 and interleukin-23. If you inhibit these cytokines, what is the problematic issue with that? There's less of these cytokines to stimulate very specific T cells. You know the T cells that respond to interleukin-12, they become Th1 cells. And the Th1 cells are the ones that release that interleukin-6, the tumor necrotic factor, alpha, which cause tons of inflammation. If we give them this drug corticosteroids, they reduce the interleukin-12, reduce the Th1 cell differentiation, and reduce this cytokine release, which reduces a lot of the edema, the inflammation, all those processes. If you reduce the interleukin-23, you reduce the conversion of the Th cells into what's called Th17 cells. Do you remember why we went over all that kind of like pathophysiology over there? If I decrease the conversion of the Th17 cells, I result in less interleukin-17, which causes all that neutrophil chemotaxis. If I reduce that, I reduce a lot of the inflammation and devastating inflammatory effects. All right, so another thing that the glucocorticoids can do, we didn't mention this mechanism over there, but it kind of gets in a little bit of too much detail. But what happens is these glucocorticoids also act on macrophages. You know macrophages? They sometimes can release another cytokine called interleukin-10. And what interleukin-10 does is it's supposed to be able to shut down, it kind of acts on itself and shuts down these macrophages and dendritic cells from releasing more of these nasty cytokines like interleukin-1, tumor necrotic factor alpha, inhibits the release of interleukin-12, interleukin-23, all of this process. So this is kind of like an anti-inflammatory function. You know what the glucocorticoids do? The glucocorticoids kind of stimulate this process. They increase the drive of this process to increase interleukin-10 production, which kind of has an anti-inflammatory type of action. So that's a really cool process there. All right, corticosteroids generally just reduce significant amount of inflammation, particularly inhibiting antigen-presenting cells, inhibiting the T helper 1 and T helper 17 cells function as well. All right, the next thing. We can utilize other drugs here. There's a drug, it's called azathioprine or 6-mercaptopurine. What is this drug called? You're like, what the heck? It's called azathioprine, also known as 6-mercaptopurine. This is also another type of immunosuppressive agent. You usually utilize this one when you're getting more to like the moderate cases of someone with Crohn's disease. So if you're getting more to the moderate cases of Crohn's disease, this would be a drug that you would go with. Now this one is definitely not going to be one to induce remission. It takes a long time to work. So because of that, it's going to be one more for maintaining remission. How does this drug work? It's actually really freaking intense. So let's say here's the area of inflammation within the GI tract wall, right? When you take this area of inflammation, you zoom into it, you obviously know that some of the culprit there is these T helper cells. You know these T helper 1 cells? They're kind of the culprit in this process because they're just blasting out interleukin-6, interleukin-1, and TNF-alpha, which is causing a lot of these problems. Well, there's a protein that is actually involved in this. This protein or enzyme is called RAC1. It's called RAC1. It's kind of, imagine it kind of like a transcription factor, if you will. What happens is RAC1 normally tries to stimulate particular genes to increase the production of these cytokines, interleukin 6, interleukin 1, TNF-alpha. When you give a drug like azathioprine or 6-mercaptopurine, these drugs particularly work by inhibiting this RAC1. So what does this drug do? It works by inhibiting RAC1. If you inhibit RAC1, you won't be able to stimulate the particular genes that are needed to make these cytokines. This results in a reduction in interleukin 6, interleukin 1, TNF-alpha. You know what else is also really interesting about this? It also inhibits these genes that are important also for the cell cycle. And because it also affects the cell cycle, guess what else this can do? This can also induce this cell cycle process to cease. So there's a decrease in the replication process and actually kind of induces apoptosis. So then you result in a destruction of the Th1 cells as well as a decrease in the amount of cytokines that these cells are releasing. And so this can also be helpful in these patients with Crohn's disease. So azathioprine or 6-mercaptopurine is another drug that you can use more moderate cases of Crohn's disease. What else? What's another drug? Another drug that you can utilize is called methotrexate. So it's called methotrexate. Methotrexate, again, is more towards the moderate cases of Crohn's disease. And again, this is going to be more for maintaining remission because it takes a decent amount of time to work. Its mechanism is a little bit more complicated. So here we have these Th1 cells, right? And these Th1 cells are the ones that are the problematic ones that are releasing all these different cytokines, right? The TNF-alpha, the interleukin 6, the interleukin 1. These are the problematic suckers, okay? Well, you know, in order for this to happen, Th cells need DNA because DNA is the code for all RNA, which is the code for all proteins. It's basically what helps the cell to be able to survive. When you give methotrexate, what methotrexate does is it actually inhibits some specific enzymes involved with making nucleotides. You know folic acid? It's actually a precursor to making a molecule called tetrahydrofolate. And all I want you to know is tetrahydrofolate or folic acid eventually gets used to make purine nucleotides like thymine. Methotrexate actually inhibits this process. It would inhibit the formation of thymine. If you don't have thymine, can you incorporate that into DNA, make more DNA, allow for the cell to be able to replicate? No. So then there's a decrease in the replication process. Another thing, there's another pathway that is actually utilized. I don't want you guys to remember too much about this, but there's another substrate that can be converted into what's called another type of nucleotide called pyrimidines. And your pyrimidines are your guanine and your adenine. Methotrexate works by inhibiting this formation, the formation of pyrimidines. You can't make guanine, you can't make adenine. So if you can't make guanine, you can't make adenine, you can't make purines like thymine, what happens to the amount of DNA? It results in a decrease in the DNA. And if that happens, this decrease in DNA reduces the replication process and may eventually lead to maybe some death of some of these cells, because they're not able to pass on some of their actual genetic material to other cells. So a decrease in this replication process may result in less Th1 cells. If there's less Th1 cells, there's less of these cytokines being released, reducing the inflammatory process. All right, so what's another type of drug that I want you guys to remember? These are the big ones, okay? So we talked about sulfasalazine for mild cases, corticosteroids for kind of the mild to moderate, and even in severe cases for inducing remission, methotrexate, azathioprine, or 6-mercaptopurine, more of the moderate cases to maintain remission. Other drugs are your biologics. Okay, so you guys got to go back. Imagine there, again, there's all that inflammation occurring here in the GI tract wall, and it's obviously a response of these problematic issues. Remember that whenever there was all that inflammation, your T cells, those T helper 1 cells, those T helper 1 cells were popping out what? They were popping out things like interleukin 1. They were popping out things like interleukin 6. But what was the big one that I really want you guys to remember? The big one here, we'll kind of beef this sucker up here. It's called TNF-alpha. The same thing, when the macrophages were activated, they were also releasing things like interleukin 1, but they were releasing tons of TNF-alpha, right? So TNF-alpha is a big culprit in Crohn's disease. So what I want to do is I want to be able to give drugs that block the effect of TNF-alpha on all of the tissues and all that massive inflammatory response. And so what I'm going to do is I'm going to give a drug that acts as an antibody and binds to TNF-alpha, inhibits TNF-alpha from exerting its effects on all these different types of cells and tissues. And these are called TNF-alpha inhibitors. And these are more for your severe cases. Okay, so more of the severe, almost refractory cases of Crohn's disease when you get to the point of biologics. These are good at actually inducing remission, but also maintaining remission. Now, some of these, they got crazy names. One of them is called infliximab. This is kind of the big one that I really want you to remember. But there is other ones like adalimumab, okay, as well. But remember, these are monoclonal antibodies, and these are drugs that are going to be inhibiting or reducing the effect of tumor necrotic factor alpha on the peripheral tissues and different types of cells within the body, reducing that massive inflammatory reaction in Crohn's. Okay, the other one, which is kind of the newer drug, is remember the macrophages, whenever it was kind of interacting with the T cells and it was stimulated, it released things like interleukin 12, which act on the T cells to help to stimulate Th1 cells. And then they started releasing all of those cytokines like the TNF-alpha, right? And all the interleukin 6 and all that stuff. And then there was also interleukin 23. And interleukin 23 acted on T cells and converted them to what's called Th17 cells. Released a ton of interleukin 17, which was also problematic in Crohn's disease. There's a drug that's been shown to be able to inhibit interleukin 12 and interleukin 23 action on Th cells. And what are the names of the drugs that actually work to particularly inhibit the interleukin 12 and interleukin 23? These are called interleukin 12, interleukin 23 inhibitors. And this is actually a very specific type of drug class that, again, these are used more in the severe cases, even when patients have not really responded to the TNF-alpha inhibitors. This is a very specific type of drug. We call it ustekinumab. Okay, ustekinumab. And again, it's going to inhibit the interleukin 12, interleukin 23 activity. All right, the last one here for the medical therapies. This is really interesting, and this is why I talked about that cell adhesion process. Remember, we had these different molecules called CAMs, the cell adhesion molecules that bound with these other things on the white blood cells. What were these things on the white blood cells called? They were called integrins. The integrins that were bound to these white blood cells, like the macrophages, the neutrophils, the lymphocytes that were coming into the area of inflammation, there's actually very specific components called alpha 4 beta 7 integrins. And we have drugs that actually can target these. So they're monoclonal antibodies that actually target, they specifically target these integrins. And when they bind to these integrins, they block the white blood cells from being able to come out of the blood into this area of where all the inflammation that'll induce and exacerbate Crohn's disease. These are called your alpha 4 beta 7 integrin drugs. And this drug that we utilize in, again, the severe refractory cases is called vedolizumab. This is an alpha 4 beta 7 integrin antibody blocker. This is another drug that we can give to patients with Crohn's disease, more in the severe case. All right, last but not least, if we've tried all the medical therapies, and again, in a kind of a step-up fashion, if you really wanted to know the perfect step-up fashion, you should, in the guidelines, start with sulfasalazine in the mild cases. If that doesn't work, then you go to corticosteroids. Generally, you try things like budesonide, the controlled release, first. If that doesn't work, then you can go to the PO, prednisone, or the IV methylprednisolone. Try to induce remission. After you've done that, then you step up to trying things that will maintain remission, like azathioprine or 6-mercaptopurine or methotrexate. If that's not working and you're still having a flare, you're not able to maintain remission, you go to the TNF-alpha inhibitors, like infliximab, adalimumab. Then, if that doesn't work, you can try other drugs like ustekinumab, which is the interleukin 12-23, and an alternative to that is a vedolizumab, which is an alpha 4 beta 7 integrin blocker. All right, so let's talk about the surgical therapy. So if a patient has Crohn's disease, right, and maybe they have some very diseased segments, maybe they have like an area that's really, really diseased and it's just non-functional anymore, we have to go and resect that portion. That may be a surgical option for a patient. So there may be the need for resection. The other thing is, especially with those strictures, with strictures, sometimes you can actually go in and actually dilate those areas. And so sometimes dilation of a stricture may be another option for a surgical procedure. Here's the big thing, what I really want you guys to take away from the surgical therapy. This is not curative. This is not curative. In comparison to something for ulcerative colitis, it would be curative because if you remove that actual segment, it would actually be helpful. But in a patient with Crohn's disease, this is not curative. Okay, very, very important to remember. Now, the next thing is surveillance. When we have a patient with Crohn's disease, they're at high risk of colorectal cancer. That's because, again, they have that disease segment. They're having continuous replication to repair that epithelial barrier. There's obviously a risk of mutations with that. And so because of that, they need to get colonoscopies earlier than those individuals who do not have Crohn's disease. And so you should get a colonoscopy 8 years after Crohn's disease diagnosis, or diagnosis of primary sclerosing cholangitis may also be another reason. Okay, so these are the big things that I need you to remember. All right, engineers, we covered so much on Crohn's disease. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.